Lung cancer definitely is a huge burden in our oncology practice. And through the journey of the lung cancer, quite a lot of our patients do require critical care at some point of their lifespan. To take us through the nuances of critical care management in lung cancer, I would like to invite Dr. Ullas Batra, Co-Director, Medical Oncology at Rajiv Gandhi Cancer Institute, to take us through this difficult situation.
Okay, good morning and very sedate morning and a very heavy dose of ARDS and management was told to us by madam. So when I was asked to speak on critical care management in a patient of lung cancer by Dr. Praveen, my first reaction actually was like, it's almost like asking a fish to, we're asking her to teach a fish to swim. It's critical care management. I mean, हम तो आपसे पूछते हैं कि करना क्या है. I mean, how do we know what is right? And I was like, this is not happening. If I start speaking about ventilation and BiPAP and NIV to you guys, it is not really going to be the right thing. My subsequent reactions on that was, let's do one thing. Tu mujhe suna, main tujhe sunau, not apni prem kahani. At our age, the only prem kahanis that we have is of our patients. I mean, that is all that we talk about. So to me, it is better to learn from each other. Let us learn the nuances of critical care from you. Let us learn the nuances of oncology treatment from us. And to me, I honestly believe that we are nothing without each other. It is like, it is a team effort, and there is nothing that I can do alone or you can do alone, and it's a team approach which is there. So why are we even talking about lung cancer on a Saturday, beautiful Saturday morning with daily AQI of only 52, 53? If you look over here, the lung cancer incidence is 67,795 and lung cancer mortality is 63,475. So if you look at the mortality board, most of the cases that will die are of lung cancer. That is because it's a bad disease. I mean, it is not my fault, it is not somebody else's fault. It is basically a bad disease that is basically going to happen, and that is why this is very, very important. It's very, very scary actually. So how do I decide? I'll talk about lung cancer, and you think about critical care management. So when a patient with non-small cell lung cancer gets admitted to ICU, there are two questions that I ask: whether should we treat the patient aggressively or should we not treat the patient aggressively? I mean, that's the first question that comes into my mind. Why do we decide not to treat? If the patient has got an advanced disease, if the patient has got a poor biology of the disease, if the patient has got a poor performance status, these are the patients you are not supposed to treat very aggressively. Do not ventilate, do not intubate, do not be very aggressive in their management. On the other hand, if we decide to treat, the complications of lung cancer can be because of the critical care requirement can be because of the disease itself. It is a bad disease. It's maybe a complication of some neutropenia, febrile neutropenia, anything. It could actually be a drug toxicity. I mean, and that is something which we need to tell you. There can be a lot of drug toxicities and new drugs that are coming up which can lead to this problem. So let's start with the case scenario 1. We have a 35-year-old female who was diagnosed as small cell carcinoma stage 4. She was given etoposide carboplatin. The revaluation showed progressive disease. That basically says that it is a bad disease to come. She was treated subsequently with 2 more lines of chemotherapy. Latest PET scan basically shows a progressive disease. She was wheelchair bound, PS4, dependent on family for even activities of daily living. You don't even have to, she just can't even go to the washroom on her own. She presents to casualty with a history of increased breathlessness. BP is 80/50, mmHg, SpO2 is 75% on room air. And as usual, a code blue or something is announced and she is taken up to the ICU. Now, this is a very important. I always tell my residents, don't even look at the patient's condition right now. Look at the patient's condition previously also. So this was her X-ray around 4 months back, and this is her X-ray right now. So the disease has just taken off. The lady has got small cell lung cancer. She has progressed on 3 lines of treatment. This was the CT scan on 21st of March, and this is the CT scan right now. So this basically brings us to the first law of oncology, which I've actually learned from Dr. Doval, which basically is knowing which patient not to treat aggressively, knowing when to say no. A lot of time Dr. Praveen will agree, I'll come to the ICU, everybody will look at this and I'll look and then say, isko jaane do yaar. I mean, why do you even want to treat them aggressively? Because this patient, whatever you do, it is a bad biology of disease, they will not do well at all. So, for this patient, critical care unit, yes. Very great critical interventions? Absolutely no from my side. I will go out and tell the patient, boss, kuch nahi hone wala, ghar le jao, and then we'll see from there. So tip number 1, in oncology, the biology of the disease trumps the anatomy of the disease, because I'm going to show similar pictures like this in which I would have treated aggressively. But the biology of disease is very, very important, which trumps anatomy of the disease. Let's go to cycle case number 2. And the only cases that I'm going to show, all real cases that I'm going to show, which we treated in our unit. 55-year-old female, diagnosed case of non-small cell lung cancer, stage 4 adenocarcinoma. NGS shows a HER2 new mutation. This is just to say, that we do good work. It can be anything over there. She got 6 cycles of chemo followed by immunotherapy. On progression, she was started on ADC. She was given trastuzumab deruxtecan. Actually, a clinical trial patient in Charu is also here. Tolerated well. PET scan after 2 cycles was near complete response to treatment. She came on cycle 4, day 8 with history of breathlessness and cough, and she required BiPAP support. Now, when it's a clinical trial patient, you are very, very cautious about it. You want to do everything and all. And we got a CT scan done on the same night. And this is what the CT scan showed. You can see the ground glassing infiltrates, and you always, and the lady was in a bad state. He was in a bad state. So we got a quick literature search. We looked at the management guidelines of that, toxicity, the TMGs of that. And they basically found out that the ILD and pneumonitis basically, it's a very, very common thing. In lung cancer, you have 12 to 13% of patients who get ILD. In breast cancer, you have 3 to 4% of people who get ILD. So we looked at this, we presumed it is an ILD, and we took the patient off the trial, we started giving her steroids. But is it only ILD? Could it be something else? Why just because a drug has been given, why is it only this? It could actually be drug-induced toxicity, it could be disease progression, it could be viral atypical pneumonitis, it could be PCV pneumonitis. Since it was a trial patient, again, we did everything over there. She underwent a bronchoscopic biopsy. The bile came positive for PCP. She was started on Septan 21 days. Patient walked back home. So yes, tip number 2 as far as I am concerned is trust your knowledge but verify. Do a bronchoscopy, do a biopsy, confirm, and you have to perform due diligence, because that is very, very important. It could jolly well have been that we would have given her steroids, the patient would have never ever recovered from this. So that is also very, very important. Do the investigations just to rule out everything else. And even the guidelines say that, before you label someone as an ILD, do the bronchoscopy, do the lavage, and do other investigations. So that's something else. Case number 3, 60-year-old male. This was in the heights of COVID that we saw. Recurrent CA lung. I think he had taken some 40 cycles of nivolumab by that time. He also took Covishield vaccine on 3rd of February 2022. That was the time that Covishield vaccine was being started over there. Just remember this. So 31st January, he got nivolumab. 3rd February, he got Covishield. Fever, he got on 5th February to 9th February 2022. This was the heights of 3rd wave of COVID, when even everybody in my unit also got COVID. Got breathlessness. Oxygen requirement was 10 liters per minute for him. This was a scan that was done for him. And if you look at this when we presented this scan in the tumor board, it was like a super scan. Everything was so blatantly, picking up over there that we really thought that we were going to lose the patient over here. Now the differentials over here, it could be COVID, it could be IO-induced, it could be viral pneumonitis, it could be bacterial pneumonitis, it could be anything. It could be the vaccination side effect to that also. And this is what we were feeling at that time. Ki ab main kya karoon? We don't know. So when in doubt, again do some more investigation. He also underwent bronchoscopy bile. I remember this bronchoscopy was done inside the ICU. Dr. Rajiv Goel's team came. There was no evidence of bacterial viral infection. He was tried on high-dose steroids, methylprednisolone. Took steroids for 10 to 12 weeks. Now, very important is when you want to give steroids for a viral pneumonitis, 2 weeks is good enough. If you want to go for immunotherapy, radiation pneumonitis, 4 to 6 weeks is good enough. But if you have to give for an immunotherapy-induced pneumonitis, you have to give for 10 to 12 weeks. You have to give a slow taper. That's very, very important. We have not yet re-challenged with immunotherapy. Patient is absolutely okay now. 2 years, 2.5 years down the thing is absolutely all right. So again, tip number 3, do not get fooled by the fancy advertisement for immunotherapy. The side effects are real. You will get pneumonitis, encephalitis, meningitis, nephritis, myocarditis, pancreatitis, something. You will get that. The more and more you'll get, the more and more you will realize how to diagnose them early and how to pick them up early. So that is also very, very important. Another patient, a 45-year-old female, diagnosed case of stage 3 non-small cell lung cancer. She had a comorbids of 40% ejection fraction, received CTRT 60 grade 30 fractions, and then was given durvalumab. She got 6 cycles, and she got, again, she came back with increased breathlessness. Again, it could be RT pneumonitis, it could be IO-induced pneumonitis, it could be acute cardiac decompensation, it could be new viral pneumonitis, it could be disease progression. So we got a CT scan done, and as you can see, as you can see here, we have a kind of a conservative changes somewhere over here, and this is also here. So the treatment is, how do you differentiate? So this lady has got pneumonitis. Now whether it is an RT pneumonitis or an IO-induced pneumonitis, what is the treatment used for them? Do you re-challenge? So how do you differentiate RT pneumonitis versus IO-induced pneumonitis? Is very, very simple. You look at it, if it is generalized, if it is bilateral, more likely to be immunotherapy. If it is unilateral in the RT field, it is more likely to be radiation pneumonitis. How do you treat? If you steroids. If it is radiation pneumonitis, give it for around 4 weeks. If it is IO-induced pneumonitis, give it for around 10 to 12 weeks. Do you re-challenge? I don't. I mean, typically depends on the grade. If it's grade 3 and more, we don't re-challenge. If it's grade lesser, we do re-challenge over there. So what do you do when you hate your job? Every Thursday in the tumor board, we hate our job. So there is a place called as, there's support group for that, which is called Everybody Hates Their Job, except for Private Dr. Doval. And we all meet at bar at 8 o'clock in the evening, where Pankaj gives us drinks, which we don't drink. Okay. So tip number 4, it's a radiation pneumonitis. Do not always blame the medical oncologist. You know, you have other friends also. You have radiation oncologists, you have other people also. You can go ahead and blame them also. Keep your eyes and ears open about what exactly is going to happen with that. So some nice cases over there. Another patient, basically, you have a 55-year-old female, EGFR mutant non-small cell lung cancer. She initially underwent surgery for 4 cycles of chemo, given erlotinib. She had disease relapse in the brain after 2 years, again COVID years. She was tried on osimertinib. She presented to ICU after 7 days with history of breathlessness, and this is what we actually got this thing. And a CT scan was just showing a disease in the brain, was absolutely normal. We gave her osimertinib. 7 days later, she comes back with this. And the relatives curse you with that, you know, कि इतनी महंगी दवा भी दे दी और देखो मेरा patient ICU हुआ. And you know, sometimes he said, the patient actually told me, sir, हम तो चलते फिरते लेके आए थे. So I then looked at him and gave some bullshit idea. But then I looked back at Amrita and said, ठीक तो बोल रहा था यार. I mean, ऐसा गलत तो नहीं बोल रहा था. So again, it could be OC induced, PCP, COVID, whatever. We did a bronchoscopy again, came positive PCP. We started on steroids and Septran. She recovered well, and within 15 days, the scan was like this. So absolutely fantastic. She was not very willing to take osimertinib. कि नहीं sir, बहुत महंगी है, problem हो गई थी. So I said, okay, fine, doesn't make a difference. After 4 months, she again came with a headache. Now we had to give her osimertinib because osimertinib is the only thing which will cross the blood-brain barrier. We restarted her on osimertinib, and this is what happened when we restarted her with osimertinib. And this guy, the guy only didn't even look at me. He actually looked at me with very threatening eyes. He said, the dare you give this medicine to me once again. We again got a PCP test done for him. Again came positive. We again tested him for this thing. But that time in tumor board, we decided that no. I mean, 2 incidents, the temporal association does not really believe that it is because of that. It is most likely a case of osimertinib-induced pneumonitis. And then we looked at whether the drugs can cause pneumonitis, and we actually find out that with osimertinib, the chances of getting a pneumonitis is actually around 4%. That is not a small number at all. 4% is a number that you get a symptomatic ejection fraction decline with trastuzumab. And we'd keep on doing an echoes every 4 weeks and every 2 weeks in pertuzumab setting. So these kind of things also does happen. So tip number 5, it is not just a pill. You know, I mean, sometimes when the things come positive, we tell them, come on, it's just a pill, sab theek ho jayega. It's not just a pill. You please read the drug insert carefully, and the common sense is very, very important. Talk to the people, do the investigation properly. That's very, very important. This patient basically came with a chronic smoker. He had facial puffiness, breathlessness, cough. Scan was done, which basically showed, a mass in the right upper lobe, which is impinging upon the superior vena cava. And this is something which is very, very common. I thought if I keep on showing you only osimertinib immunotherapy, you will say ki, it is better not to take treatment. So sometimes it is better to, I will show you some this thing also. So superior vena cava is also very, very important. I mean, in small cell lung cancer, we see More importantly, when the patient comes to ICU, very important is head and elevation. Do not place cannula in the upper limbs. Use cannula in the lower limbs. Start steroids. Restrict the fluids. Do a good IO charting. Look at the underlying pathology of the disease. If it's lymphoma, give steroids. If it's thymoma, go for surgery. But very importantly, which I want to say is SVC stenting. We have the IR department over here. And if you actually do a SVC stenting, it is very, very, very gratifying. And the patient actually improve very well. In fact, the radiation oncologists in our hospital do not want to give radiotherapy, and they actually want to go ahead and give stenting for them, which is a very, very important thing. You can always give a palliative radiotherapy and chemotherapy also after that. So tip number 6, lung cancer is a multimodal problem, and please do not ignore other specialties. Again, as I say, it's a teamwork. It is a teamwork. I cannot do everything alone. I need the help of my radiation oncologists, IR department, surgeons, because A, they have much more things in their armamentarium. Second is, it is always good to blame somebody else also. We should not be the only ones to get blamed over there. 2 more cases. This patient has basically got, this is a case which is just got recently, around a month or 2 back. 47-year-old male, never smoker, came with breathlessness. A very small mass, right lung, upper lobe nodule, bilateral lung nodules. The guy was not able to lie down straight. He was at a 45-degree angle. We got an echo done, mild RA-RB dilatation, nothing really great over there. The patient was ALK rearranged. At that time, LVEF we done, slight RBD was dilated. We got a D-dimer done for the patient, which came as 10,000. So we got a CTPA scan done, and as you can see over here, it's got a bilateral pulmonary thromboembolism. So that is also was what we gave him Clexane, and LMWH and TKIs beautifully responded, absolutely doing absolutely great. Duration of DOACs in this patient, at least 6 months, maybe continued for a long time. Tip number 7. It is not always about the lung parenchyma. Look at the vasculature also. Sometimes, a lot of time only an HRCT scan is done. A HRCT scan will miss out on a pulmonary embolism. Although sometimes after this patient, we did get CTPA scans for 2 more patients, and Dr. Praveen, you were right. We did not get any thromboembolism in those patients, but yes, you win some, you lose some. Okay, this is a nice one. Just the second last one. 65-year-old male, chronic smoker. He came with a history of breathlessness. Diagnosed and treated stage 4 non-small cell lung cancer. We gave IO chemo followed by immunotherapy. Latest scan shows an increase in the left lung mass, and this is what it was. So we did a bronchoscopy. The pulmonologist did a bronchoscopy, and they found out that the left main bronchus was basically occluded, and everything else after that was absolutely clear. So this is, you see a very small patent bronchus, and the entire thing was with the mass. And then this was a scan done. I will just show you images over here. Okay, just see, they did a debulking for this patient, and in 40 seconds you will find out. Yeah, just look at this now. Look at the way the tumor is just being pulled out of that, and the patient who was requiring 10 liters of oxygen and BiPAP support slept without oxygen the same night after that. We did give him brachytherapy after that, and the patient was absolutely okay. And this is the, I didn't have. The X-ray after that was absolutely fantastic. The lung had fully expanded. And before Dr. Pinky sleeps, last case, 9th one. So this was a patient, right lung mass with adrenal and multiple skeletal mets. He came to casualty with altered sensorium. When somebody comes to you with altered sensorium, got an MRI brain done for them, absolutely normal. CBC, LFT, KFT done, normal. Now what happens is, in some labs, including ours, we don't do calcium in the KFT. So CBC, LFT, KFT hua, ho gaya normal. Patient was in altered sensorium. We didn't do a calcium. So then the patient went over there to the ICU, and then we got an ionized calcium done. So in lung cancer, in head and neck cancers, somebody comes to you with altered sensorium, please do sodium and ionized calcium. That is very, very important for us. Management of hypercalcemia, I think every resident in the first year knows very, very well. Give IV fluids, give Lasix, give steroids, give calcitonin. Please have a look at the KFTs also. That is very, very important. Sometimes in a creatinine of 3, you will go ahead and give them this, and then you have a cardio reference. You can give bisphosphonates and denosumab, and in rare cases, dialysis may be also required. So tip number 9, chemical locha is a true formality, true thing. It does not exist only in Munna Bhai MBBS. It also exists in a real this thing. Look at the sodium, potassium, look at the calcium, and that is also very, very important. So, critical care requirement in a patient of lung cancer in a nutshell, 2 ways. It could be disease related, where you require a BiPAP or a non-invasive or invasive ventilation. You can have concurrent infections. You can have viral, bacterial, fungal. You guys know more about that than what we do. It could be thromboembolism. Suspicion is very, very important. It could be advanced disease. It could be an SVCU or a spinal cord compression. It could be metabolic. It could be hypercalcemia. It could be hyponatremia. It could be brain mets. So these are general what normally we see in our daily practice. It could be treatment related. It could be chemotherapy. It could be nephrotoxicity. It could be chemotherapy induced. It could be target therapy, IO, ADC induced, which could be pneumonitis, neuropsychiatric effect, hyperlipidemia, and something else. So to conclude, lung cancer is a heterogeneous disease. A lot of new therapies have come, and that is the reason why lung therapy specialist is talking more in front of you at 9:30 in the morning, which have increased the treatment, the prognosis of lung cancer. A journey of therapeutic nihilism to realistic optimism. That's a line I take from Dr. Dowell. I think we used to take this line around 10 years back. However, these drugs are costly and they have their own toxicity. They are just not any normal off the shelf you can take. A careful consideration of drug, disease, anatomy, biology, molecular biology of lung cancer is very, very important. The biology of the disease, I always say, it trumps the anatomy of the disease, and that is the way it is going. A team approach is a must. And to conclude, I will say it's the team approach which basically gets you in a much more better way. It is a saying, that family that eats together stays together. I have just modified this statement with saying that the teams that take ICU rounds together are the ones which get their patients out of ICU faster. Whether to downstairs or to upstairs, I don't know, but they did get their patient out of this thing. With this, thank you, and I'm sure there are no questions with this. Thank you. Any question, I'll be happy to answer.
Thank you, Dr. Ullas, for such an energetic talk.
I have to go to ICU after that also, no?
Yeah. But for the juniors, the hardcore concept of critical care management of these cancer patients remains the same. You have to look about the ventilatory management, fluid management, and infection control. Apart from that, you have to be aware about the specific complication of a specific subset of cancer patients. As already given with the example of SVC syndrome complications, that is very important. Sir, as a medical oncologist, there is always a tussle between an intensivist and an oncologist when to let go the patient, or when a medical oncologist say to us, this is the time to pull the plug.
Correct. So I started my thing by saying the anatomy, the biology of the disease trumps the anatomy of the disease. You have to look at the biology. I always say, do I have a plan B for this patient? And that's what I counsel my patients. That even if we are able to get you out of this scenario in less than 5%, 10%, you will have the same scenario once again. So, and that's why, and we also talk to the intensivist saying that, okay, fine, is it worth the effort? I put a term called as ROI, there's something called as a return on investment. Is it worth the investment that you are doing if the biology of the disease is not very good? Let's say the first patient has taken 4 lines of chemotherapy, there is not much that I can do. I actually let the patient go. But is there something in which I can do this much? I would be very, very aggressive. And that's the first question which I and Dr. Praveen, when we call up, whenever she calls up in the morning, I'll say, Dr. Praveen, let's be aggressive. If she comes out, fantastic. Otherwise not. And sometimes, jane do. And that is where the biology of the disease, that is where very clear communication is very, very important.
Yes, it is the teamwork.
It is the teamwork. That is what I showed. The team that takes ICU rounds together, that is where you decide.
This is an excellent take-home message for any specialty.
Any specialty. And we need to talk to each other. That's exactly the most important thing, because ultimately it is not about medical oncologists or critical care specialists. It is about patient.
Yes. And dying with dignity is also one of the
very, very important
aspect of the oncocritical care. Thank you so much.
Thank you.